Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Dual Effect of Metformin on Breast Cancer Proliferation in a Randomized Pre-Surgical Trial by Bernardo Bonatti et al. My name is Jennifer Ligabell, and I am a medical oncologist specializing in breast cancer at the Dana-Farber Cancer Institute and an assistant professor of medicine at Harvard Medical School. Interest in metformin, an oral biguanide used in the treatment of type 2 diabetes, as a potential anti-cancer agent initially arose from observational evidence suggesting that higher levels of insulin at the time of diagnosis were associated with an increased risk of recurrence and death in women with early-stage breast cancer. Metformin lowers serum glucose levels through AMP kinase-dependent inhibition of hepatic gluconeogenesis and stimulation of glucose uptake in skeletal muscle. Lower systemic glucose levels in turn lead to decreased insulin secretion. Thus, metformin leads to lower systemic insulin levels as opposed to many other agents used to treat type 2 diabetes, which increase insulin secretion to overcome insulin resistance. Observational studies subsequently demonstrated that diabetics treated with metformin were significantly less likely to develop and die from cancer as compared to diabetics treated with other therapies. For example, Curry and colleagues evaluated the relationship between metformin use and cancer risk in 62,809 type 2 diabetics in the United Kingdom and demonstrated that individuals treated with metformin monotherapy had the lowest overall risk of developing cancer. Diabetics treated only with sulfonylureas had a 36% higher risk of cancer, and those treated only with insulin had a 42% higher risk of cancer as compared to diabetics treated with metformin alone. Interestingly, patients treated with both metformin and insulin had a 50% lower risk of developing cancer as compared to diabetics treated with insulin alone. Observational reports also suggested that metformin could enhance treatment response in breast cancer patients. Investigators at MD Anderson reported that diabetic patients treated with metformin during neoadjuvant chemotherapy experienced significantly higher pathologic complete response rates as compared to diabetics receiving other diabetes drugs, with pass CR rates of 24% in the metformin-treated patients versus 8% in diabetics treated with other agents, p less than 0.001. Pass CR rates in diabetic patients treated with metformin were also numerically, although not statistically, greater than pass CR rates in non-diabetic patients, 24% versus 16%, p equals 0.10. Additionally, preclinical data suggests that metformin inhibits breast tumor formation in animal models and suppresses tumor growth in cell lines. Given this converging observational and preclinical evidence, there has been much interest in elucidating the mechanisms through which metformin could impact malignant transformation and progression of breast cancer. Metformin has been hypothesized to impact breast cancer both indirectly through insulin-mediated pathways and directly through activation of AMP kinase, which triggers downstream signaling pathways and ultimately affects the mammalian target of rapamycin, or mTOR pathway. To date, in vivo data regarding the effects of metformin on biologic processes in breast cancer cells are limited. One recent window of opportunity study from Haddad and colleagues randomized 47 non-diabetic women with newly diagnosed breast cancer to 2 weeks of metformin or placebo. The study's primary endpoint was change in the percentage of cells staining for Ki67, a proliferative marker that has been shown to have prognostic value in early breast cancer. Ki-67 percentage decreased during the 2-week study period in the metformin group, p equals 0.027, but not in the controls. The study also looked at changes in gene expression after metformin exposure and found that AMP kinase, mTOR, tumor necrosis factor, and other pathways were affected. This podcast focuses on a window of opportunity study by Bonani and colleagues, which also evaluated the impact of a brief preoperative metformin exposure upon levels of Ki-67. The trial randomized 200 non-diabetic women with newly diagnosed breast cancer to 4 weeks of metformin or placebo. The metformin dosage was 2 850 milligram pills daily, and the drug was stopped at least 24 hours prior to surgery given the small risk of lactic acidosis that has been reported in patients taking metformin. 50% of study participants were premenopausal, 40% were overweight or obese, 27% were insulin resistant, and 85% had estrogen receptor positive tumors. Compliance with study procedures was good. More than 95% of prescribed doses of metformin and placebo were taken. Diarrhea and nausea were the most commonly reported toxicities and were more common in the metformin arm, p less than 0.05 for both. The median time between the last drug dose and surgery was 67 hours, with a range of 21 to 75 hours. The authors did not find a significant relationship between metformin use and change in Ki-67 over the 4-week intervention period in the study population as a whole. Median Ki-67 was 19% at baseline and 21% at surgery in the metformin group, and 18% and 20% at these two time periods in the control group, p equals 0.40. However, in a pre-specified analysis stratified by homeostatic model assessment, or HOMA, an index of insulin sensitivity, metformin use led to a non-significant 10% proportional decrease in Ki-67 in women with baseline insulin resistance, but no decrease in women without insulin resistance. In exploratory analyses not corrected for multiple comparisons, metformin was also found to lead to a proportional decrease in Ki-67 in women who reported moderate alcohol consumption, women with higher BMI or waist-hip ratios, and women with higher levels of C-peptide. The authors concluded that their study provides additional evidence that metformin may have anti-tumor activity, but hypothesized that this may be limited to patients with baseline insulin resistance or metabolic syndrome. These findings are provocative but warrant further confirmation in ongoing and future studies of metformin in breast cancer populations. It is important to note that patients in this trial stopped metformin on average 2.5 days before surgery. Given the short half-life of the drug, it is possible that direct AMP kinase-mediated effects of metformin could have been lost, and that insulin-mediated effects, especially in patients with normal insulin sensitivity, could have been dampened during this washout period. A third window of opportunity study evaluating the impact of metformin upon Ki-67 and other biomarkers in women with newly diagnosed breast cancer has completed accrual, and results are expected in the near future. Additionally, the MA32 study, a randomized adjuvant trial which will test the impact of metformin on invasive disease-free survival in 3,582 women with early-stage breast cancer, has a robust correlative component which will further elucidate the mechanisms through which metformin may impact breast cancer development and progression. Data from these studies will help to guide the further development of metformin as an anti-cancer agent and will help define the patient populations most likely to benefit from the drug. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.